Endovascular parashitum, who's going to be speaking about Phoenix atherectomy use in the common femoral and popliteal arteries.
Thanks for this opportunity. So that's the title of my talk, and nothing relevant. So, there's a lot of studies we see out there with regards to atherectomy in CFA and Popliteals, but specifically looking at calcified CTOs, there's not many. Probably the most relevant with regards to Phoenix is the N-Mobile. And then they had close to 28 Popliteal and close to 10 patients with CFA CTOs. So this is a front cutter, essentially as an Archimedes screw. It was around 10 to 12,000 revolutions per minute. So this is a single center study from 21 to 24, just one operator, all comers, and the relevant patients were referred to surgery, and those who were turned on were included in the study. So we had 51 patients with 51 limbs. I only included the index procedure, and only these were denable transfemoral stenosis. So these are my demographics as expected in that part of our country in the US for a sick patient population. These are the medications, and it's also not many of them, out of the 51, only 32 were on statins, and this is due to intolerance and other issues. These were their prior interventions. So again, underlying the fact that this is a sick separated population. So close to 50% of 43, were CLTI patients with a combination of ischemic breast pain and non-healing wounds. Most of it run were electively seen in the clinic and then brought to the hospital. And this is the distribution, the CTO segments we included in our studies. So we had predominantly Popliteal Artery, and then the next group was obviously the CF and C tax classification. So a good chunk of them were TAS C, them the severely calcified based on the TAS per kg. So these were the procedural details. So most of the procedures we were able to complete first and all. The procedural success with the diuretic therapy was close to 100%. As long as the technical success goes, that as soon as you pass the atherectomy once or twice, we were able to restore kidney flow. And then they were treated further on. Half the patients we used this. And then those are the devices used, predominantly the 2-4 and the 2-2. These were the adjunctive therapies. So one patient had a perf who ended up getting a Viabon. The bunch of the others who got some superiors and drug-eluting stents were predominantly the distal SFA involving the P1 segment, and one patient did get superior in the P2 segment. So this is the safety data, which to me is important, especially even for its high-risk patient population, that we had only one perforation, which did require bailout for stenting. And interestingly, I did perform IVUS on this patient, and there was one spot which looked suboptimal, but maybe he was not too careful when advancing the device. So here's a case. This is our calcified LINC CFA CTO involving the ostium of the SFA as well as that of the profunda, and you can see the calcium density almost as dense as the bone. So we performed an IVUS. A lot of these, I do this to make sure my wire is really true luminal. If it's not, then I try to rewire it. So that's the device advancing. It's a 2-4 deflection. This is after a single one. It managed to achieve flow into both the SFA and the profunda. This is after performing the chop and then a DCP. This is a case where you have the CTO involving the P2 and the P3 segment of the Popliteal, which also involves the nephropop vessels. And then that's the flow all the way down the foot, just to the peroneal. So we use the 2-2 straight catheter, advance it all the way to the TPT flow. And these are the cases where I find IVUS useful to assess the size as well as the calcification. As a case, I also perform an IVUS after one run of atherectomy. If I had satisfaction fragmentations calcium, then I feel confident putting in a specialty bully. So this is again after ballooning, we were able to restore good flow. In this patient, I did end up stenting right in the junction. This took is the dissection is there, and this was a non-healing E, and that's the flow all the way down to the site. So at 6 weeks, we had 45 patients who came back to us, and one of the reasons we had difficulty with follow-up is the next hospital from where we are is literally 250 miles. So this is in a real rural country. So the 45 patients, all of them had the average peak CFA velocity was not significant. Same with Popliteal, the ratio was less than 2.4 PC. The case, 40% had complete resolution. Some came back to the stage SFA intervention, CLTI, rest pain, we had
complete resolution, and the rules 40% showed complete PE. And some of them followed up with us, some followed an outside center. Probably had a major amputation. One patient did die 20 days later from a endovascular hyperemia with cardiogenic shock. So the 3 patients who came back to us in the Q-MANC follow-up, who had CTOs, one developed stenosis of the CFA, referred the surgeon, turned down, ended up getting a stent, did well. And the 2 other ones then with punctured re-occlusion, which was again re-intervened endovascularly with good success. So the limitation is obviously it's a single center, a single operator studying things. I think the main problem with on-demand head is this, the fact that we didn't have good follow-up at least patients. So to know truly the efficacy of this is really challenging. Also that we used a lot of adjunctive currently different pans, so very little of the T's out, what's really adding to the benefit. So in cases like anxiety, short-term for the safety goes, you use pretty safely. You at least follow up to 6 weeks is pretty decent.
Okay, this guidance is very helpful, especially when we're trying to do calcified chronic total occlusions. About very few thought applications, which is very reassuring.
And obviously the 6-month follow-up and the UTFs very reassuring. Take care.